Good morning, everyone, and welcome to today's Readmission Refuel Project Kickoff. Thank you so much for joining us. We have a couple brief housekeeping items to cover before we start our session this morning. We ask that you please take a moment and check to make sure your phone lines or your computer audio are muted. We appreciate your attention to this as it does help us avoid background noise during our session. We also ask if you need to step away from the session today, please avoid placing the call on hold so we don't have your call waiting background music playing in the line. We encourage you to ask questions throughout today's session. Please utilize the chat box throughout the webinar to type in questions as they come to mind. We'll be sure to answer all the questions submitted through the chat either during or at the end of the session. Lastly, this session will be recorded and transcribed. It'll be posted on Hinnovation in approximately 5 business days, so you may access it or share it with other members of your team. All project documents, presentations, and recordings will be archived in Hinnovation under the Resources Library tab in the Readmission Refuel folder. Without further ado, here is the agenda for today's webinar. We're going to be starting with a welcome and introductions. We'll be giving some brief readmission refuel announcements, and then moving into our Phase 1 project content. Know your data, identify your high-risk target population, and engage your team. We'll wrap up with a Q&A session, and then we'll be reviewing next steps together before we adjourn. I want to welcome you all and thank you so much for joining us. My name is Kate Carpenter and I serve as a Quality Improvement Advisor for the Compass HIN. I'm also the project lead for the Readmissions Refuel Project. It is my great privilege to introduce our advisor on this project, Dr. Amy Boutwell. She is the president of Collaborative Healthcare Strategies, a national thought leadership, strategic, and technical advisory firm specializing in strategies to achieve high-value care, improved whole-person care across settings and over time, and focused primarily on reducing acute care utilization among the highest-risk populations. Dr. Boutwell is a nationally recognized expert in the field of reducing readmissions and improving care for high utilizers, advising statewide initiatives to reduce readmissions and improve care for high utilizers in several states, and nationally through the CMS Hospital Improvement and Innovation Network. She co-developed the ARC Hospital Guide to Designing and Delivering Whole-Person Transitional Care, called the Aspire Guide, which is the foundation of the Readmissions Refuel Initiative. Dr. Boutwell is a graduate of Stanford University, Brown University School of Medicine, and the Harvard Kennedy School of Government, where she received the Robert F. Kennedy Award for Excellence in Public Service. She is trained in internal medicine at Massachusetts General Hospital and practices hospital medicine. We are honored to have her presenting on all 3 Refuel Project webinars and are grateful for her willingness to partner with Compass HIN on this work. Before I hand it over to Dr. Boutwell today, I want to make a few brief announcements and remarks as we kick off the Refuel Project today. For the past several months, we've been designing this project to help support the Partnerships for Patients goal to reduce readmissions by 12%. Last November, this project was announced, and we have been really excited to see your interest in the response to refueling your readmission efforts. To date, we have had 31 hospitals enroll in this project and make their commitment to participation. This slide shows our cohort across the state for your reference. I encourage you to take a look at this slide and make sure you see your organization listed. If you do not, please call or email me so that we can get you formally enrolled in the project and issue you a copy of the Refuel Participant Guide. For those of you who did not formally enroll in the project but have chosen to join today and listen to today's webinar, we're so glad that you're here. We hope that you'll find the information helpful and that you may find ways to incorporate these ideas and advance your work in partnership with your improvement advisor. At this time, I'd like to drop in a quick poll. If you are listening with your team today, please indicate the number of people you have listening. You'll see this poll launch in just a moment. Many of you are responding. We'll give that just a moment to finish up. Just a few hospitals left to respond. Thank you all for your responses. With that, we're going to end polling and share those results. You'll see the shared results display soon. Very good. So we've got some of you listening alone today and several of you listening along with your teams. Lastly, here are a few reminders and announcements I want to draw your attention to as we commence our work. As you will recall, the Refuel project is broken into 3 different phases of work. The project guide was sent to your organization's project lead following your enrollment, and it does contain some detailed project information to help you keep on track with the different timelines and due dates and action items. So make sure you keep this close at hand and reference it often as your work progresses. I also want to make sure that you have your team all registered for the 3 project webinars. The webinar links and information can all be found in the project guide. I also want to remind the cohort that one of our commitments to you with your participation in this project is that you may request coaching or support from the project team during each phase if you wish. If following today's webinar you would like to schedule coaching, please email me your request so that we can schedule your coaching swiftly with the most appropriate resource to meet your needs. You'll also have an email coming the end of the week. Project leads will be receiving this hopefully by week's end, and it will contain the cohort's full pre-survey so that you can review those results as you wish. Additionally, it will contain some brand new readmission reports our data team has designed to aid you in your phase 1 work of the project. So we're excited to be sharing those with your teams. You'll also be receiving the phase 1 survey that is required for your participation. You'll be receiving this via email on February 7th, and it'll be due back by February 16th. At this time, I'm going to hand the presentation over to Dr. Boutwell to present the phase 1 project content. Good morning, Dr. Boutwell, and thank you for being with us.
Great. Thanks, Kate, and welcome everyone. Thanks so much for joining the Readmissions Refuel initiative. It's great to be with you, and I really appreciate Kate and her team bringing me on board. So as you know, phase 1 launch webinar. So today we're going to talk about data, target population, and the appropriate team to address the needs of your target population. So let's get started. Next slide. So first of all, as we think about this refuel concept, we recognize that, of course, many of you have been working on readmissions for quite some time, but at the same time, one thing that I've learned over the many years of working on readmissions is that we have started started and stopped and refreshed and relaunched readmission projects time and time again over the many years. And that's pretty much a typical state. And so one thing that we really encourage you to do as you join us here at the beginning of a new year and a new commitment to readmissions work is to refresh your understanding of your data. And so what I'd like to do is share with you some ways in which I have come to slice and dice readmission data in ways that gives me new insights and allows us to really identify target populations that we might not have thought of before. Next slide. Next slide, or advance there. So I'd like you to think for a moment, and actually, please, this is a chat question. If you would chat in for me, who do you consider high risk of readmission? Who have you been focused on in the past? Which target populations or patient populations have you been looking for and targeting as you try to implement efforts to improve care transitions and reduce readmissions? Okay, great. Thank you, Ellie. Ellie typed in end of life and nursing home patients, substance abuse patients from Laura. Thank you. Sepsis from Lisa. Excellent. Pneumonia and CHF from Cindy. High LACE scores from Denise. COPD, CHF, sepsis, elderly, those with comorbidities, malnutrition, CHF and COPD, patients going to skilled care. Excellent. And the penalty conditions. Excellent. This is so helpful. Thank you. Elderly with chronic conditions. And then those from home who refuse home health and are in declining health. We've got concerns, of course, about patients who don't adhere to their self-management and disease management. We have people, we know that people who are on medication assistance are high risk. Excellent. Thank you to all of you for using the chat. This is fantastic. Advance, Kate. And of course, you can ask yourself why those patients. So you can see across our membership cohort here today, we've got teams that are focusing on diabetes, CHF, COPD. We've got other patients who are focused on patients going into skilled nursing care. We've got other teams focused on substance use. So while I love all of these target populations, ask yourself and your team, why are we focusing on who we're focusing on right now? What is the genesis and what was the reason why we decided to use a high LACE score or substance use or discharge to skilled nursing facilities or chronic diseases as our target population? And think during this session, do we want to stay with that population? Do we want to amend it, expand it, or modify it for the year to come? Question. Do you know of high-risk patients who are in your hospital who don't fit whatever target population you just articulated? So for Colton, for example, whose team's focusing on the elderly patients with chronic conditions, can you think of other patients in your hospital who are at high risk of readmission that you're not currently focused in on? So too with Janet, who's focusing on the penalty conditions, or others who said they were using the LACE score, et cetera. Can you type in a few patient groups or types of patients who are at high risk who don't currently fit into your target population? Oh, interesting, from Nancy. Some moms, expectant moms. Okay, thanks, Nancy. Anyone else have thoughts about high-risk patients that you're not? Yep, Jackie says mental health patients. Absolutely. So, and we're going to talk about that briefly in terms of what the data show. We really started on this journey thinking very much about chronic conditions, and yet for some reason we didn't remember that behavioral health conditions are also chronic. So thank you, Jackie. So great. Thank you so much. Okay, next slide. So one thing that I'd like us to think about is, all of us got started mostly on reducing readmissions, focused by the really important and powerful messages that that were sent through the Medicare readmission penalty program and policies. And you know what? Those messages have been helpful, and they've focused us in on some really important groups of patients that no one would argue with: COPD and CHF and pneumonia. those are really important groups of patients to think about. But think about this, and really you can see some of your colleagues have come to think about this as well, is think about this. Has the construct of the Medicare penalty program affected the way we think about high risk? And so one observation that I make is that because the penalty program is associated with payment and billing, right? They associated high risk with certain primary diagnosis codes, right? So of course, you all know what those ones are. And the food for thought here is, as we go through the data, notice that although heart failure is often at the very top of the list, AMI, pneumonia, COPD, hip and knee replacement, and CABG, those are not always in the top 5 or 10 diagnoses leading to the most readmissions. So it's really important to know, yes, we would focus on the penalty conditions because we don't want to get penalties. But it's also important to ask ourselves, why are we focused on a certain set of conditions, and are we missing anything? Are there any blinders that the focus in this area has caused us to not look in another area? In addition, point number 2 is it's really focused us on the Medicare population. And to be sure, Medicare and older adults have the preponderance of readmissions, but we'll look at a little bit of data in terms of age and payer that might make us think, should we be worried about people who are not limited to Medicare, but maybe on an all-payer or including Medicaid, for example? And then number 3, a diagnosis focus in terms of, are we looking for specific conditions? It limits our understanding of other ways of thinking about high risk of readmission. And when I work with accountable care organizations and really advanced population health groups, guess what? That's what they're looking for. They're looking for unmet social needs and behavioral health, not just psychiatric, but behavioral health, including substance use and maladaptive behaviors. They're looking at functional status. Do people have cognitive limitations? Do they have dementia? Do they have functional limitations in their ability for self-care? And so you can see classically we haven't thought about these issues in terms of how to screen for a patient for high risk of readmission if we're only looking for diagnoses. But those of you who are clinicians and at the bedside, you would know full well if you are taking care of a patient who has active substance use disorder, we would predict that they are at high risk of readmission because they're not likely to be able to manage their self-care over time. Similarly, people with cognitive or functional limitations, we would really need to make sure that we're attending to their support care needs, not just their diagnosis-specific needs. So with that as an invitation on our Refuel efforts here, think about, why are you focusing on the group you're focusing on? And are there important patient groups in your community, in your hospital, that we're not focusing on that maybe we want to in the year to come? Next slide. So let's go now through, I'm going to go rather quickly through just a slicing and dicing of some all-payer, all-cause readmission data. And again, this is food for thought and an invitation for you to ask yourself and your team, should we look at our data in this type of a way as well? So here we see all-cause, all-payer readmission data, and something in all of these slides where you see this color scheme. This is an analysis looking at adult non-OB readmissions. Okay, in your HIN you might look at kids, you might look at OB, but these next set of about 5 data slides, they're the adult non-OB population, age 18 and over, all causes. So what you can see here is in the orange line, this is the average all-cause, all-payer readmission rate for adults, and this happens to be from the state of Massachusetts. And what you can see in the first small box is every single adult insured by a private health insurance plan, commercial. So the average readmission rate in Massachusetts is 15%. But anyone who's insured by Blue Cross or Aetna or United or Cigna or whatever it is, regardless of having COPD, CHF, diabetes, and being whatever age, interesting, has a much lower readmission rate than average. Now, we move into Medicare, and of course, we see the most readmissions in the state of Massachusetts are from Medicare. That's why the box is biggest. And they have an above average readmission rate. So again, this is every Medicare patient, regardless of disease or discharge setting, and they're the ones who are really kind of bringing up that rate in Massachusetts. But the interesting and actionable finding here is this third box. Every single adult non-OB Medicaid patient hospitalized for any reason going to any discharge location has a equally high, if not a tiny bit higher readmission rate than our Medicare population. And so again, question one is, as we focus on Medicare, have we had a blinder to Medicaid? Next slide. This is a second high leverage way of thinking about data, and I can tell that some of you have already picked up on this signal. This is readmission by discharge disposition. So what you're seeing here again is that same average readmission rate at 15%, all cause, all payer for adults. And here is the surprising fact. Look at everyone discharged to home. We have been taught in readmission literature that we need to be very concerned about that voltage drop, the discharge, the transition from hospital to home. And to be sure, we need to make sure that people have a high quality, effective transition to home. But interestingly enough, again, regardless of age, payer, or comorbidities or primary diagnosis, everyone discharged to home actually has a lower than average readmission rate, around 12%. Whereas everyone in the state, again, regardless of diagnosis or comorbidities, everyone discharged into post-acute care, whether that's skilled nursing facility, home with home health care, or to acute rehab, has a very high readmission rate, much higher than average. Well, this makes sense to those of you, again, in case management, discharge planning, nursing, and hospital medicine, because, of course, these are the people who qualified for post-acute care. So by definition, they had ongoing skilled care needs. But instead of saying to yourself, well, these people are sicker and they have greater needs, which is a fact, what I would propose is that you ask yourself, normally day to day, I think that if I get somebody to accept home care or to agree to go to a skilled nursing facility, that is a safe discharge plan that will mitigate their risk of readmission. What I propose to you is the very fact that the patient in front of you is being discharged to post-acute care should be a signal to us that we need to do more, not less, in the days following discharge in order to collaborate and respond to needs such that the patient doesn't need to be readmitted to the hospital. Next slide. So now here is a helpful to many readmission teams, especially people new to the field and new to readmission committees. The very first kind of grumble we hear, right, is, well, it's not fair. 30 days is much too long, and it's outside of our purview, and it's not something that we can control, and who knows what's going on out there in day 28, where they come back, and what could we have done? Well, while those things certainly are challenges, what you're seeing here on this slide is a frequency chart of the days in that 30-day time period. And it says, among all readmissions that occurred within 30 days of discharge, among all of our readmissions, on what day post-discharge did the readmission occur? And what you can see is that fully a third or more of all of our 30-day readmissions are coming back within a week. And we're going to see some more Iowa data on that. But this is an invitation that says, if you or your committee is concerned about the 30-day trajectory, well, a great place to focus first and foremost is what is going on in the days immediately following discharge, and certainly we can do better with this 1 week time frame. Next slide. So the next, this graph here happens to be from South Carolina. It's one of the most complete sets of data we have, other than your new hot off the press Iowa data, where we have readmissions, the top 10 discharge diagnoses leading to the most readmissions in the state, by payer and total. So this is really important, because what I want you to look at is the Medicare list first, because most of us know our Medicare readmission patterns really, really well. And we're expecting to see, of course, CHF, pneumonia, and AMI, COPD on this list. So take a scan through the Medicare column, this first column here, and you see pneumonia is at number 3, COPD is at number 4, and we go all the way down to number 9 to get to heart failure, which is really surprising. Now, this is again, the discharge diagnoses leading to the most readmissions by payer and overall. So what you can see is the number 1 and number 2 here, at least for the South Carolina folks, they were a real surprise. And apologies to those of you who don't, who aren't familiar with this clinical shorthand. Number 1 here is acute renal failure. Okay, so acute renal failure. Number 2 is sepsis. Now, moving over to the Medicaid column, again, this may or may not be relevant to all parts of Iowa, but the teaching point is that when we looked at Medicaid, instead of assuming that that CHF and COPD were kind of high readmission diagnoses across the board, in the special case of South Carolina, sickle cell is at the top of the list. And you'll notice I put in parentheses the number of readmissions, and I did that again for a teaching point. I'm well aware that sickle cell may not be a pressing issue in Iowa, but for some of your facilities in the urban areas, it probably might be. But the teaching point here is to look at the number of readmissions for sickle cell. It's not only the number 1 diagnosis leading to the most Medicaid readmissions, it's the number 1 by a factor of 3 to 1. Not even close. It is the leader by far and away. And so the insight that each of you can get from looking at your own data is, again, what have we assumed about readmission patterns? And when we look at our data through a fresh lens and a new perspective, have we missed any important signals? Of course, you can imagine in South Carolina, the entire statewide readmission committee said, oh my gosh, how did we miss that? Now it's so obvious, but it wasn't obvious until we looked at the data. And then, of course, for planning purposes, it's important to look at the total column, which is, overall, what for our hospital, in this case, the state, what are the discharge diagnoses that are leading to the most readmissions. So you can see we could come up with a Medicare, Medicaid, and overall strategy focusing a little bit beyond COPD, pneumonia, and heart failure, and really pick up a lot more readmissions in high-risk patients in our efforts to reduce all-cause readmissions. Next slide. So this is picking up on what some of you have put your fingers on already, which is behavioral health, the relationship between a behavioral health diagnosis and readmission risk. Sadly, this is not in the LACE score. This is not in most risk screening tools. And I really encourage you to take a look at this information with your team. To my knowledge, this is the best data that we have. What we did with the Massachusetts, again, all-cause adult data, is we looked at everyone who had been hospitalized in the year who had any behavioral health diagnosis. So everything from anxiety, depression, obviously through to schizophrenia and bipolar, including substance use disorder. Okay, so the full spectrum of behavioral health conditions. And we said, and we split population into two groups. Do you have any behavioral health condition? Do you not have any behavioral health condition? And what you can see, again, regardless of age or payer or discharge disposition or primary hospitalization reason, anyone hospitalized who did not have a behavioral health condition had a lower than average readmission rate. Anyone in the hospital who had any behavioral health condition coded in their record had a 77% higher readmission rate at 20%. This was the only stratification we did for literally everyone hospitalized in Massachusetts. The question is with or without, and you can see that the single screening question of, does this patient have a behavioral health condition, would be a very robust way to identify a high risk of readmission patient. Next slide. This is the slide that taught me not to be ageist when thinking about readmissions. Now, we already talked about Medicaid, and so that's kind of the first signal. But here what we're looking at is national discharge data, and it's for everyone discharged with a primary diagnosis of heart failure, okay? So this is our bread and butter readmission focus area, and everyone discharged for heart failure. Well, of course, we have been accustomed to looking for the Medicare beneficiary who is over age 65 who has heart failure. But look at this national data. When we look at all payer, all age, what you see on the left-hand side of the screen is that the younger patients with heart failure have every bit as high, in fact, a teeny bit higher readmission rates than the older 65 plus heart failure patients. Very counterintuitive until you talk to the nurse and the doctor taking care of them who says, that makes all the sense in the world. If you're 43 years old and you have had a series of medical events that have resulted in you having heart failure as a young or middle-aged adult, of course there are many, many, many other things going on, right? It's a marker for having many other social, behavioral, and medical issues for a person who has developed heart failure at a young age. So if you're focusing on heart failure, ask yourself, are you looking for anyone with heart failure? Please don't stratify by age. So too, do you see here on the right-hand side, which is of course Medicare, Medicaid, and then commercially insured. We see the same pattern as that overall pattern I showed you at the top of the presentation, where surprisingly, the Medicaid adult with heart failure has heart failure readmission rates that are 25% higher than the Medicare. So, and then the commercially or privately insured patient is relatively protected with a lower readmission rate. So again, take-home message from this slide is even within a chronic disease category like heart failure, where we're all focusing, ask yourself, have we only been looking for Medicare? Have we only been looking for age over 65? And if so, you're probably missing some heart failure patients who really need your attention. Next slide. I think this is one of my last slides from elsewhere that I want to share with you. And this is, of course, about high utilizers. And so what you see here is we looked at, again, all patients hospitalized in Massachusetts, and I have come to use the definition of an inpatient high utilizer. What we found is if you've had 4 or more admissions in the past 12 months, that's 2 standard deviations above the mean, and it's a very helpful cutoff. So we use that cutoff, 4 in 12 months. And we found the classic population health pyramid here. 7% of all of our hospitalized patients met that definition. They used 25% of all hospitalizations in the entire state. And get this, they accounted for nearly 60% of all 30-day readmissions. Now, this is something that we intuitively know. Again, now that I say it out loud, you say, yep, high utilizers, of course they're causing all of our readmissions. But it's very helpful to have the data in front of you. And here's a really interesting fact. Just like I told you, the difference between patients who were discharged to home versus post-acute care is a huge differential. So too is the discharge for anyone with or without a behavioral health condition, a huge differential. Well, here's the third huge differential, which is the readmission rate for those multi-visit patients is 38%. In counterpoint, the readmission rate for anyone who's hospitalized 1, 2, or even 3 times, for anyone who is not categorized as a multi-visit patient, their readmission rate is 8%. So hopefully what you can see from this kind of brief overview of slicing and dicing data is that you can find ways other than diagnoses, or in addition to diagnoses, to identify some really robust, bedsideable, memorable ways of identifying risk that your nurses, your docs, your case managers will really make sense to them. They could ask themselves, is this patient going to post-acute care? If so, they're high risk. Does this patient have a behavioral health issue? If so, they're high risk. Does this patient have a history of multiple visits in a year? If so, they're high risk. So hopefully this will get you to think about your RACE score or the diagnosis-specific conditions that you have been looking for. Again, not wrong, but just some other ways of looking at your target pop. Next slide. And so Amy did ask us. I've got 2 other slides here. So this slicing and dicing of data, it comes from a tool that I developed in the Aspire guide, and it's referenced in your Refuel initiative packet. It's a simple 15-point readmission data analysis, and that this is something that hospitals can do for themselves, if or any part of this if you're interested. Next slide. And this is just a screenshot of a live Excel document that we developed, again, downloadable on the Aspire Toolkit site, which you all have access to, which actually helps create some visuals that could be helpful to you. And it also has in the narrative right-hand column, you can see in the screenshots, it has some interpretation cues and guidance to help your readmission team interpret what you might be seeing. Now, all of this is great, but you know what's even greater, next slide, is the fact that your Iowa HIN has done this for you. And so I am just so amazed and grateful to Kate and her team for requesting this data from the Iowa Hospital Association. And I'm going to go through some of this literally hot off the press, we got it last night data. And you can see that you have a lot of this data, and you'll be getting it, as Kate said, at the end of the week to inform your refreshed look at your readmission data. And so what you're going to look at here is Iowa overall, and then Kate tells me that each of you are going to get a facility-specific report. So this is a little friendly announcement to say, if you haven't formally enrolled in the collaborative, I would recommend you do, if for no other reason than to get this data report, because it's fantastic. So you can see what I want to point out here, these are just excerpts of the report that you will have access to. So what you can see here is Iowa's readmission rate by county, it looks like. And of course, a little heat map for the blue is lower readmission rates, and the red are hot spots with higher readmission rates. So again, hopefully you can just identify what part of the state you live in, and especially notable if you're up there on the red spectrum. Now, the next thing that you see here on the right-hand side of the screen is I believe equally helpful. So in readmission work, we're always talking about the readmission rate, right? Which means the number of readmissions over the number of discharges, okay? What the right-hand side is showing in this table is showing, which is the total number of readmissions. And that is also very, very helpful information. So we can see that Polk County, of course, has the most readmissions, and this was a 6-month window, if I remember correctly. And then you can see how the readmission rate for Polk County is 8%, so the rate doesn't look that, quote, bad, but the number of readmissions is very compelling. So of course, I know overall in Iowa, you in general have lower than average readmission rates for the country. But what we want to encourage you to do is say, yep, we might have lower than average readmission rates compared to the country, but man, the country's a mess. And we know we can do even better than what we're doing right now. So you always want to toggle between that readmission rate, which might be 8, 9, 10%, and the readmission number, which are the number of human beings who are coming back to your facility within 30 days of discharge. And both of those inputs can really help guide your efforts. Next slide. What you're looking at here is the top. Now I didn't have time to convert these ICD-10 codes into diagnoses, but we'll chat about helping you do that. But what you'll see in these reports are, again, they ran the top 10 diagnoses leading to the most readmissions in the first column, so the most readmissions. And then they ran the diagnoses with the highest readmission rates. And then they also showed you the diagnoses with 5-day, leading to those 5-day or less bounce backs, and what the readmission rates were for that. So these are, again, nuanced and advanced ways of looking at not only the readmission rate, but the readmission number and those early bounce backs, if you will. Next slide. And here's another cut of the report that you will see, which is, again, that timing, days between discharge and readmission. And again, just like everyone else, there's a spike there on those early readmissions. And so a great opportunity for the refresh is to ask yourself, what is going on with those 0 to 5-day readmissions, or those 0 to 10-day readmissions? And you could see you could get a lot of leverage in reducing readmissions, even if you just focused on that first week or two. The next frame here that you see in the middle is readmissions by length of stay. And we know that, well, actually, there's a misnomer, I would say, in amongst hospital teams, case managers and discharge planners and nurses and doctors that say, well, as length of stay has gone down, readmissions have gone up. But look at how we would need to interpret this Iowa data here in the middle. It actually says, and I have seen this, so I believe what we're looking at here. It says people with longer than average length of stay have the highest readmissions, right? It's that bar goes up at a length of stay that is over 6 days. And basically, if you're there over 6 days, it doesn't matter if it's 6, 10, 15, or 20. If you're over 6 days, what this Iowa data is showing us is that you're at high risk of readmission. So that a longer hospitalization is not protective against a readmission event. Again, using data to bust our myths and misperceptions about who really is at risk of readmission. And then this last slide here is also really helpful. I'll tell you, I cannot tell you how many people hypothesize that discharges on the weekends lead to the most readmissions. Well, I have seen this type of a data report time and time again, and it's always the same results. Can you believe it that discharges on like a Tuesday lead to the most readmissions? It just kind of breaks that idea that that there's something going on with the day of the week. And so you can see here on the table that actually Saturday and Sunday readmissions have the lowest readmission rate, which again is just a helpful way to check your assumptions, and it really means obviously that those weekday that we're not perfect on the weekdays either. Next slide. I think we got one more data table, maybe. Yep, one more data table. And this, I congratulate the HIN for doing, which is, this is the real data, the race, ethnicity, age, and language. And so, of course, what we have here is readmission rates by age. in the first chart. And you can really see, again, why my focus area, when I think about reducing all-cause, all-payer readmissions, I'm really talking about, for my discipline, the adult population over age 18. And in fact, it's really, what our Iowa data shows us, it's really age over 40. But importantly, I would really encourage you to cast your net all the way down to age 40. If you've been looking at age 65 plus, then really look at the data here. And of course, you'll look at your own hospital data and say, oops, we are really missing those people who are being hospitalized in their 40s and 50s. And we're, they have high rates, and we're missing them if we're not looking at them. And then we've got men and women. This is the same story kind of everywhere. Women always have slightly lower readmission rates than men. I don't really know what to do with that information. I don't really use it operationally, to be quite honest, but there you have it. And then we have by race and ethnicity, and some highlights here. Again, really helpful to see the Iowa-specific data, because of course this is not the same as it is, in other parts of the country, where I found it very interesting to see that the readmission rate for white Caucasian folks is not different from the readmission rate for African American and Black folks. So that's really interesting and helpful data. We do have a little spike with the American Indian Alaskan Native population. And then I'll tell you what, I do see this across the country, that Hispanic or Latino ethnicity or Asian origin usually does have a lower readmission rate. And so that, I can tell you, I do see that in the national data as well. So again, very helpful to identify areas where we need to put some more focus. And I think the clearest signal I see on this slide is to make sure you're looking at the adult over 40 population. Okay, next slide. So with informed by data, then of course you can see the whole point of taking a refreshed look at your data is to ask yourself, who should we be focusing on? Should we adapt, expand, modify our targeting criteria? If you're using race, ask yourself, are we capturing these various aspects of high risk of readmission? If you're using, diagnoses, is there something about age that you need to, expand, or elderly, do you want to expand, etc.? So let's talk a little bit about target population identification. Next slide. So this is an exercise I'm going to really ask you and your team to do, which is to ask yourself, what is our readmission reduction aim? And some of you might want to even type it in. Of course, the overall HIN aim, our collective aim as a quality improvement collaborative, is to reduce all-cause readmissions by 12% by the end of this year. But every hospital might have its own specific readmission reduction aim statement. And so an aim statement is comprised of specific elements. What are you going to do, which is reduce readmissions? For whom, which means what specific target population? The whole hospital, heart failure patients, Medicare penalty patients, patients with a certain target population, high risks, and by how much and by when. So that's, for our purposes, 12% by the end of the year. So I'd encourage you to bring to your next team meeting or your debrief after this webinar, make sure you have specified your readmission reduction aim. What, for whom, by when, and by how much. Then you would ask yourself, according to your aim, what does your data show? It shows that post-acute readmissions are high, readmissions for behavioral health patients are high, readmissions down the age spectrum are high, etc. So then you'd ask yourself, oh, and I should also add, sepsis and renal failure and those other diagnoses that we haven't been focused on before. So then we ask, okay, now that we have clarity on our aim, now that we know specifically what our data shows for our own hospital and our own communities, who should we focus on? Who should we now redefine or reaffirm is our high-risk target population? And so that's where you would want to say, we will focus on patients with X, Y, Z risk factors. And then, and we'll get into this in later phases, but then through an understanding of why those patients come back, we should design our improvement interventions and services, transitional care services. Food for thought is a lot of times I meet teams and they have gone through these questions in the opposite order. So what I mean by that is they say, we've got a transitional care pharmacist and she's doing post-discharge phone calls for COPD patients or polypharmacy patients, you know, and they've decided on the intervention, and then they've decided who they will deploy that intervention to, and then, you know, and then they kind of skip the data part and they hope that the intervention deployed to, you know, polypharmacy patients will help achieve their overall readmission aim. So really, I challenge you to think through this provocation I'm giving to you, and can you start at the top and work through the 4 questions in series, and have you started at the bottom by saying, we're going to do transitional care callbacks for COPD patients, because that was the strategy you had available to you at the time. Next slide. So here's a couple, 3 examples. I have hospital A, B, and C. These are all actual teams that I work with. Example hospital A, their aim was to reduce all-cause readmissions hospital-wide. Their data shows that their hospital-wide readmission rate is 12%. That's adult non-OB. Again, we all have our little differences in definition. So adult non-OB readmission rate, 12%. They found in their data that readmissions among patients discharged to post-acute care settings, 16%. They found in their data that readmissions for patients with behavioral health conditions, 17.5%, and they found the readmission rate for multi-visit patients was 30%. So in the spirit or in the quest to reduce all-cause readmissions, they decided to focus on 2 different target populations. The first population was all patients discharged to post-acute care. The second population was all patients with behavioral health conditions or who were high utilizers, multi-visit patients. And they recognized that those were epidemiologically two distinct groups of patients, so that they were going to run 2 different programs or intervention models, if you will. So that's one example of a team who used their data to identify a target population that then led to 2 very different readmission programs at their hospital. Next slide. Hospital B, well, their goal straight up, they had to reduce heart failure readmissions. There's no question about it. They had a problem. They don't like those penalties. They know it's a classic improvement imperative to reduce heart failure readmissions. So that was their focus. Their data showed that their hospital-wide readmission rate was 12%. The readmissions among all heart failure discharges, 16%. The readmission rate among all Medicare heart failure discharges, 16%. Readmission rate among privately insured heart failure discharges, much lower, 12.5%. And by the way, they then realized that, Blue Cross, that around here, Blue Cross and the other private plans had disease managers from the plans working with these patients. Readmissions among all Medicaid heart failure discharges, 17.5%, and readmission among all heart failure discharges into home care, 20%. So based on this data, they decided to focus on heart failure discharges who had Medicare or Medicaid, but not deploy the resource to the privately insured patients, because there was going to be a warm handoff effort to make sure that their disease manager knew about them. And secondly, to work with the home care agencies on a heart failure specific home management protocol and improvement effort. So we're going to focus on heart failure patients of a certain type, and we're going to work with the home care agencies because of that data point that we see. Next slide. The third example is Hospital C. Their aim was to target the top diagnoses that resulted in the most readmissions to their hospital. So they wanted to reduce hospital-wide readmissions, and they wanted to do that through targeting the top diagnoses. So again, their hospital-wide readmission rate, 12%. Their top diagnoses leading to the most all-cause, all-payer readmissions at their hospital, sepsis. Their sepsis readmission rate is 18%. They then dove into the sepsis part, and they found that the number of sepsis discharges per year, 375. That means what I like, the reason why I like to do this is to quantify it, is that you say, okay, so there were 375 sepsis discharges in the year. How are we going to build a program around 375? Well, you say that means there's about 30 per month, and holy smokes, that's 1 per day. We can do this. We can really do this. They found that 50% of their sepsis discharges were to home and 50% were to post-acute, so they were going to need to have a two-part focus. They found that about a third of sepsis discharges were Medicaid, a third were Medicare, and a third were other. So they were not going to be payer specific on this. So they thus, based on their data, they chose to target all sepsis discharges of any age, any payer, and any discharge disposition. And they know that they can do this because they quantified the total number of sepsis discharges that they're going to need to intervene on, staff up for, pay attention to, is 1 per day. And they decided as a team that was imminently feasible. Next slide. So hopefully you can see that we want you to really use your data, not just to become more knowledgeable and educated, which of course is necessary to have a great readmission effort, but also to really use that data in your strategy and the design of your readmission program. So you know exactly who you're going to focus on, and you can quantify that. So the third message of today is engage your team. Now, the great news here is that we heard from your survey that you have absolutely, all of you that reported the survey, you have the highest level of executive support in your organizations. And for that, I really congratulate you. You're very fortunate. And so that's great. So now let's just take a few words to connect the dots between refreshing your understanding of your data and your target population. And now let's bring that refresh into who do we need to work with on our team? Who do we need to engage on our readmission reduction team? Next slide. So this is a quote kind of from Any Hospital USA. This was the director of case management. She said, "We run the Navigator pilot. I think nursing is working with IT on getting a high-risk flag in the record, but I don't really know how that's coming along. I think there was a SNF collaborative at one point, but I'm not sure if that's still going or not," right? How many of you kind of have that sense that you know what you're doing, you kind of think other departments or stakeholders in the organization are busy doing other good things, but you're not quite sure? Next slide. So I would recommend that as at this refueling stop, at our refuel refresh, you take the time as a team to even go beyond your classic readmission team and ask yourselves, are we really updated as to the various transitional care, high risk of readmission, disease management, service line specific initiatives, all of which in one way or another would probably help to reduce readmissions. So this is kind of recognizing that readmission efforts have proliferated over time. Nursing, case management, IT, maybe hospital medicine, maybe maybe there's a CHF clinic or a special program of some sort, and just really make sure that you take the time to refresh your own knowledge and your own team's knowledge of what's going on within your own hospital or within your system or your network of organizations. So this is just a little checklist here to jog your memory. Next slide is a tool I developed in the Aspire guide, which is, just called the hospital inventory tool. And by no means, should there be activity, checks across all of these boxes. Again, this is just meant to be a prompt and an inquiry to, ask yourself, to identify what you don't know, right? And so ask yourself, is there a readmission flag, for example, or do we have centralized scheduling, or is somebody making post-discharge calls, or is anyone working with our patient and family advisors with regard to readmissions or with regard to patient interviews? And so just this tool might be helpful to you to inventory what's going on across the different departments of your hospital, and make sure that that first of all, about what's going on, and second of all, as per our topic here, you just might find someone that you'd like to invite onto your readmission team that you didn't realize could be a valuable member. Next slide. So just as we sometimes lose track of exactly what's going on within our own hospital, we definitely lose track of what's going on across the community. And, community resources and assets and leaders and partners and stakeholders and grant-funded initiatives or whatever you have, they change all the time. And this is one of the most challenging things that we in the hospital have to deal with, which is really keeping pace and track and updated with what is going on in our community settings. And so community here is very, very broad. It includes, what are your skilled nursing facilities doing with regard to transitional care and readmission reduction themselves, so too with your home health agencies, so too with any patient-centered medical homes or accountable care organizations that are operating in your community. They all have care management and population health management initiatives, if there are any in your area. And then moving into the classic definition of community supports, what about, the elder services, the social services, transportation, food, faith-based organizations, other groups that can provide behavioral health supports or peers or navigators, county mental health departments, etc. And so I work, again, I'm so fortunate to work coast to coast and in so many places in between, and very, very many rural communities. And one thing I hear is, you don't understand, there's just no resources in our communities. But what I really do encourage you to while I know that there are not enough resources, what I have seen with my own eyes and what I have seen really, really work, especially in the rural communities, is that you can leverage the resources that do exist. And the creativity and the camaraderie and the can-do spirit that I have seen leverage, the office, one charismatic leader in one community organization can really mobilize and bring benefit to your high-risk patients who are living, without caregiver support or without transportation. So as we recognize that there aren't enough resources, which is certainly true, I would encourage you, as you embark on this refresh, to say, well, what resources do we have? And are we working with and aware of all the, whatever resources do exist in our community? And so again, you might just use this as a little prompt and checklist to ask yourself, have we looked around every corner we can to find potential partners that could meet our patients' needs, especially when we're thinking about those groups on Medicaid or with behavioral health needs or social needs that we're not classically able to deal with easily in the hospital setting. Next slide. So, as you think about putting together your team, the biggest thing I hope to contribute to your thinking about your readmission team is, yes, everyone has an executive sponsor, and that is essential. The next thing is your own hospital-based team, and that's the team that many of you are with today, right now. And of course, it's interdisciplinary in nature, and I hope it is interdepartmental with IT, quality, case management, social work, nursing, maybe pharmacy. There have been some great rural hospital stories I'll share with you using the one pharmacist you have in the hospital, hospital medicine, and patient advisors or volunteers. But I really encourage you also to think of your team as a cross-continuum team, and to make sure that you are thinking about, with reference to your data and your target population, who is on your cross-continuum team. And if you come through this refuel phase wanting to focus on the younger adult or adults with behavioral health issues or sepsis or whatever the case may be, ask yourself, what post-acute and community-based providers or agencies do we need to recruit onto our cross-continuum team, because we're going to be handing off to those folks, and we really want to make sure that we're collaborating and communicating effectively in that handoff. Next slide. So here's just a few quick examples from that those hospital A, B, and C, just to kind of point out what kind of teams they have. I'll be quick as we kind of come to the end of our time here. But you can see that Hospital A, who's focused on all-cause readmissions, specifically patients discharged to skilled nursing facility and those with behavioral health conditions, they have their hospital-based team that would look familiar to you. Their executive champion, an analyst, IT, quality, social work, case management, nursing, and importantly, the emergency department, which we'll talk about more in phase 3. But I wanted to put that on your radar screen, especially important for post-acute care readmissions and behavioral health / high utilizers. Our emergency room is going to be a center of gravity for this work. So I wanted to give you a little forecasting on that one. And then their cross-continuum team, well, Team A is a post-acute care team. That makes sense. Team B, they had to put some effort into identifying and engaging the administrative leader of a behavioral health clinic that has some peer navigator support available, a Medicaid managed care plan that has a care manager assigned in the area, and transportation resources. So again, many of you know to work with skilled nursing facilities or home care agencies, and that's obvious for Team A. But what you might need to do is put some thought into your new refresh target population and who are the behavioral, or who are the specific cross-continuum agencies that will help you with your new or expanded target population. So in the interest of time, I think that kind of captures the teaching point. So I'll ask Kate to flip us through example B and C, which you can reference on your own. And I'll summarize by kind of restating the specific 4 kind of refueling stops we hope you will take and work through in this first phase of your work. Number 1 is take a new look, a fresh look at your readmission data analytics, asking yourselves kind of the questions that we walked through today around who are we focused on and why, who are we missing, and do we need to, and what do we see in our own data. Number 2 is not just what do we see in our data, but use that data to inform your targeting approach. How do you want to identify high risk of readmission moving forward? And write that down and be specific about it. Number 3 is inventory the existing efforts and resources within your hospital, within your community, and use that inventory to populate a team that might be, again, some of you, looks like you have 6 or 9 people on your readmission committee together today, so that might be exactly perfect. But some of you may not feel like you have a sufficiently robust and supportive team. And so populate not only your hospital team, but your cross-continuum team as well. And of course, engage the right stakeholders who can meet your target population's needs. So next slide. Hopefully this launch webinar has helped you refuel in some specific ways that we learned from you. You were seeking assistance. And so as Kate said, you can reach out to her and ask for coaching and guidance in this phase 1. This is what we learned quickly from you. we learned that 60% of respondents are still not quite sure how readmissions are measured. So Kate's going to pull together some more resources for you on that. Bottom line is keep it simple, but Kate can help you with the specific measurement definitions. About 50-50 of the teams in our collaborative actually use data to inform their readmission reduction efforts. So of course, we want all of you to use data to inform your readmission reduction efforts. We're so happy to see that 75% of you look at your data monthly. So again, we want to support all of you in looking at your data monthly and using it. And then 30% didn't have a specific readmission reduction goal. So of course, we want to make sure that if you feel like you're one of those teams who didn't have a specifically articulated goal, then it would be natural for you in this phase 1 to look at your data, use that data to inform what your goals should be, and we'll help you articulate a goal if you need any technical help on that. With regard to the team, you all have executive support, but less than 40% of you reported that you meet at least monthly. I would say that through the Refuel initiative, I would very much encourage weekly meetings, minimum bi-weekly meetings, or every other week meetings. And meeting monthly is good as long as you know that there's work going on during that month. But PDSA cycles really should be refreshed, you know, on a kind of an every 2-week basis, a month at most. And so again, as you form your team, as you relaunch your efforts, I would encourage you to re-establish a schedule that will help kind of keep pace with the pace that we're going to set here in the Refuel initiative. Next slide. Looking forward to the next phase, a few signals in your responses I just want to forecast for you. We are definitely going to be addressing next time is root causes. So we talked a lot today about data, and then what you're going to hear in phase 2, just looking forward, is really understanding why patients are readmitted. And the best way to understand why patients are readmitted is to ask them. Ask them, ask them. And so 30% of you already do that. And we're so excited to see that. And then 30% of you who ask them actually use that information to inform your readmission, your improvement efforts. So we want to connect the dots between those two things when we come back together again in phase 2. So this is just a little forecast of what's to come. So next slide. So now I'm just going to skim through here, probably in reverse order, and just see if the questions that were put in. Really excited that you all want data, so perfect. And so, you know, Kate has told you you will be getting the data. And Anne, Anne would like Anne will help everyone with the behavioral health diagnoses specific stuff. So that's great. Anyone else have any questions that you'd like to pose as you think about, you will be getting the data reports. Again, to reiterate, if you have any questions, if you want Kate and the team to help you interpret your data, know what you're looking at, maybe use the data to identify some potential target populations like I showed you in cases A, B, and C. That's really what we hope you'll go through is we looked at our data, we re-specified our aim, and this is our specific target population based on the data. And then we're really hoping that based on who your target population is, you'll pull together that best possible hospital team as well as cross-continuum team. So that would be great. So if anyone has any other questions, I don't see any popping up here. We really love questions, so I'm sure Kate and Anne would welcome your emails. You know, I'll be helping answering any questions that come up that I can help with. And with that, you know, we're just really appreciative of your interest in the Refuel initiative. We're so thrilled that you're with us today, and I'll turn it back over to Kate to close us out.
Thank you so much, Dr. Boutwell. We really appreciate your presentation and expertise and insight today. I hope that you all gleaned some information from the session today. Before we do conclude, I would like to provide some a quick overview of the next steps. So if you have, hopefully most of you were able to attend the live webinar today, but certainly we understand that maybe some members of your team were unavailable. So as we mentioned at the top of the session, we are recording this and we will transcribe it and post it to Innovation. So if you have team members that were unavailable, make sure that they have access to the recording. If you haven't already, we'll ask that in phase 1, you do secure your executive sponsor to support your participation in the project. Most of you have already done that. If this is an area you could use support with, please do reach out to myself and we'll be happy to provide assistance. We will be asking that during this first phase of work, as Dr. Boutwell mentions, that you're developing your Refuel team and identifying which members will be active during each phase of the Refuel project so that this can help you be proactive in scheduling to make sure those team members are available for meetings and webinars during that time frame. We'll ask that you're analyzing and collecting your current readmissions related data to help you determine your current state and areas of greatest opportunity for your organization, and hope that the new readmissions report sent out later this week will aid you in doing so. From that information, we'll be asking that you do identify a patient population for the project and create a standard definition for that population. Gather any additional baseline information or data that you may have available within your organization that you could use individually to track your performance with this patient population. As a reminder, we do encourage that if you could use coaching or support during any phase of the project, that you reach out and request that as needed, and we'll be fielding those requests via email. Lastly, phase 2 webinar is scheduled for February 28th. We'll have you mark your team's calendars and plan on seeing you then. There is a couple questions. One question, I think, Dr. Boutwell, that has come in to the chat, and before we conclude, we'll take a look at that. Being a small rural hospital, is it unrealistic to have an entire inpatient population as the focus, or do we need to break it down?
Oh, that is a great question. So, so I would say that that I take a three-part approach really quickly. I always encourage us to implement high-quality transitional care or high-quality hospital-based processes for everyone, right? That's raising the bar for everyone. We want to do a really good risk assessment on everyone. We want to do, we want to engage the patient and their care plan partner. We want to make sure goals of care are addressed and documented. We want to make sure MedRec is done. We want to make sure we're using TeachBack, and we want to make sure that we're scheduling appointments before discharge. That applies to everyone. I don't, and so I don't really think of that as only for high-risk patients. So that's the part of the Aspire model that if you go look at that information, that's one part of improvement work that I think should apply to everyone, and I don't think that is unrealistic at all. Then the other two parts are, working really well with warm handoffs and our post-acute providers. So I think that that's again part of what we should be working toward to improve the care we give at time of transition when people are going into post-acute care. And then the smallest bucket are who gets those extra services, who gets the coaching or the transitional care visits or the pharmacist MedRec visits. That would be for a certain group of highest risk patients, and that should be not everyone. It should be a limited high risk group of patients, again, according to what you have available to offer them. So I don't think it's unreasonable at all to say we want to elevate transitional care for all of our patients. And again, the I part of the Aspire model would have a little bit more information for you on that.
Very good, thank you. Folks, we are past time, so at this time I'd like to thank you for your participation and attendance in the Phase 1 webinar today of the Refuel project. If you have questions that continue to flow in through the chat, we'll answer and respond to those in writing. Have a good day and thanks for joining.